Good morning. Good morning. Where are my Sinai folks? Oh my God, there's a balcony. Okay. This is like the Beacon. This is a great venue. So thanks for having me. We're going to talk about Who Needs the LP. We're ahead of schedule, correct? So I'm going to take all that time. And, you know, as always, thank you for giving me space. I don't like the way people smell in this kind of environment. Okay, so first, disclosures, as always. I haven't been able to work that out yet, so don't have any. First case, the only case. So 62-year-old female, this is a patient I saw a little while back who I talked about on one of the podcasts that we did on this subject as well. She was actually the mother of a cardiology fellow in the institution where I was working at the time. And she came in with, she had actually been skiing the day before and had like a thunderclap headache, severe acute onset, like worst headache of her life. Never had anything like that before, was neurologically intact, totally normal, no significant past medical history, and she didn't have a lot of photophobia, she didn't have neck pain or stiffness, anything like that. She just had this terrible headache. And so we sort of, we started to take care of her and talk to the cardiology fellow after we'd done the CAT scan and talked to her, and we tried to make a decision about what comes next. So how many people, given this scenario, do the LP? How many people don't do the LP in this scenario? Okay, nobody's willing to say that out loud. How many people would think about actually sharing this decision with the patient? Oh, crossover now. Oh, okay. So, you know, lumbar puncture is the gold standard, right? This is literally how we define whether or not somebody's had a subarachnoid hemorrhage. The gold standard is not things like cerebral angiography. Those things are great, but they're anatomic. Whether or not somebody's bleeding, and this is a subarachnoid hemorrhage, can only be answered by the LP, because if the cerebral angio is positive for an aneurysm, it doesn't tell you they're bleeding, it just tells you they have an aneurysm. You can't tell whether something's leaking on a cerebral angio. You almost never get that perfect window of time where you see the little tiny drop of leak. That doesn't exist. All you can see is the anatomy. So it's an important distinction, and the question is, when we do these LPs, it might be worth knowing that according to the best literature that we have in the universe, the best prospective data where they've taken acute headaches, what they call acute headaches, in most of the settings where they study this now, an acute headache is what she had. It's the headache that within its first 10 minutes, it's already reached its maximal onset most of the time. It's the worst headache of life. You don't have a couple headaches like it in your life. This is a totally new and different headache. You don't have a history of migraines. You're neurologically intact, and you don't have known aneurysms or anything wild like that. Acute headache. In the acute headache population, how many times are you going to do an LP and then find a subarachnoid hemorrhage that's aneurysmal? How many LPs does it take? Guess? How many people have had an aneurysmal subarachnoid hemorrhage that they have diagnosed doing an LP by their hand? Okay, I got 4. 5. Okay, interesting, good. So if you follow the ACEP policy on this, which is the, you know, you've got an index of suspicion for subarachnoid, you'd have to do about 730 LPs in order to capture one aneurysmal subarachnoid hemorrhage. In the actual Perry data, they only did about 400 for everyone that they captured, but the Perry data is they actually didn't LP everybody. They had great clinical follow-up. We'll talk about that a little bit more in a couple of minutes, but that's frustrating because, you know, what's better than pop, drip, drip, right? I mean, that's like satisfying. It's one of the best, most satisfying little, you know, you got a little agua there. That's nice. So there's a couple things to keep in mind. There's the post-LP headaches, which happen, according to the literature, between 1 and 80% of the time. And the complications, fuerte, that literature. The complications are rare, but they happen, maybe 1 in a couple hundred. My wife doesn't like to admit this. She's not here, so I get to say this. But she has the only case that I'm aware of in my own circle of actually inducing an epidural abscess with actual spinal cord damage. She's a good doctor, though. I promise you, she's a really good doctor. False positives, about 15% of these taps are traumatic, and you get blood in them. But even more than that are false positive. That's just the ones that trauma is the reason for the false positive, and that leads to more tests. And then there's obviously discomfort, and there's a big resource issue because, you know, you sort of, you got to spend some time in the room doing this LP, and it takes you away from other patients, et cetera, et cetera. So the question is, can we develop a test threshold? And so what's a test threshold? Well, a test threshold is this idea that, you know, if you're looking at somebody who has a 1 in a million chance of having an aortic dissection, you don't do a CT angio for them, because 1 in a million. You wouldn't do a million CT angios for every one that you picked up. You'd kill more people than you would help, right? But when you're 50-50 that they have a dissection, you're doing it, right? At 50%, you're doing it. At 1 in a million, you're not doing it. Somewhere between 1 in a million and 50% is a test threshold, is a threshold that we could agree that somewhere near there is the point at which you're going to do more harm than good or more good than harm if you start testing in that population. So the question is, how do you find that probability below which no further investigation is actually needed? And it's, you know, lower than 50-50, but higher than 1 in a million. And it turns out that there's a calculation for this. This is the calculation. So you need to know that. Just kidding. So the calculation, I'm going to walk you through what the calculation looks like if you do it for LP, because I want you to understand just conceptually why it would be that anybody would consider, you know, doing or not doing the LP, and what this should really be based on, because you're doing a test, right? And anytime you're doing a test, you should be, in your mind, thinking about a threshold for that test. Where's it going to benefit that patient most, and where's it more likely to harm them? So here's how the calculation works out. The way the calculation worked on the previous page there is basically it's all the good things that can happen from doing an LP. You catch the diagnosis, you save a life, in the denominator, plus all the bad things that can happen. And the numerator is all the bad things that can happen. And when you put bad things over bad things plus good things, what you find is a number. And the number that you find is the percentage at which that's the percentage you need to have as a prevalence before it's even worth doing this test, or you're going to hurt more people than you're going to help. So if the answer comes out it's 10%, then 10% of your patients need to have the disease in order for it to be worth doing the test, or you're going to harm more people than you're going to help. And it depends on a lot of things like who gets hurt when you do the test, how many people are going to get that epidural abscess, and how many people are just going to fly through this procedure and do fine. So when we did this calculation, we put in the bad things and the good things, and you'll see how we did it. At the top is the false positivity rate. So the false positive rate, that's a bad thing that can happen, and it leads to certain bad things that is the next calculation. So the false positive rate's 33%. That's according to the best study ever done on this with 600 patients. Every single one of them got LP'd, and every single one of them got followed up. And it turns out 33% is false positive. The next line down is what are the risks of treating when you have a positive LP? In other words, you get your positive LP. What comes next? What comes after a positive LP? What do you do after you get a positive LP? You do that thing. Just do that thing. What do you usually do if you get a positive LP? Consult. Okay, and so that's a very harmful procedure, if I could just... It's incredibly, profoundly harmful. Actually, what's going to happen when you get false positive, a certain percentage of those patients are going to get a CT angio, right? They're going to get a CT angio of the brain looking for an aneurysm. Certain percentage of those patients are going to get admitted, maybe get an MRI. Some of them are just going to get another LP. So the range of possible bad things that can happen is down as low as about 4 per 1,000. 1 in every 250 people is harmed. And when we say harm here, we only accepted either neurologic disability or death. We're not even talking about pain, discomfort, all of that. Neurologic disability or death. So 0.44%, it's 0.044 because it's in a proportion, but it's 0.44%, which is 4 out of 1,000, up to about 1 in 100. And what we're talking about there is a certain number of patients are going to have an aneurysm, because 3 to 4% of patients walking around have an aneurysm. And when you find it in this scenario, the de facto diagnosis is they're bleeding from it. That's the de facto diagnosis. In reality, that's not true in a certain percentage of cases, but you can't tell because the cerebral angio can't tell if you're leaking or if we just found an incidental aneurysm. And incidental aneurysms rarely blow, and unless they're over a very large size, usually 6 to 7 millimeters, nobody's going to go after an asymptomatic aneurysm, and they shouldn't. Why? Because there's more harm than help. More harm than help. Why is it more harm than help? Well, you can see up here there's an 8% risk of bleeding in surgery. Neurosurgery is a really bad thing. It's a really bad thing. So if you take 3% to 4% having an aneurysm and then a certain percentage of those getting a procedure and having a bad outcome from the procedure, that's where this range comes from. The risks of actually treating once you found your LP that's positive because you got the CT angio or admitted them for an MRI or they got a cerebral angio and they had a positive. Okay. Next is benefits of the treatment. It turns out there's about a 10% difference between catching the disease early and catching it a little bit later. You don't do the CT, and it turns out they had an aneurysmal subarachnoid hemorrhage. Well, in about 10% of the cases, it's possible that you have caused a neurologic disability or a death by missing, and them coming back week, 4 days later, that kind of thing, with a blown aneurysm. It's about 10% difference in outcomes. Okay, bottom. Sensitivity to CT LP, it's the gold standard. Once you do a CT and an LP, it's 100%. So moving on. Turns out, when you put all this into the numbers, the low end is 1.6%, the high end is 4.4%. What we're saying is on the high end, you need to have at least a 4.4% chance of having an aneurysmal subarachnoid hemorrhage in order to make it worth doing an LP. On the low end, 1.6%. So we converted that into, imagine there's a confidence interval around that. We said, we want to get to 1% or lower. We're being very conservative about this. Turns out you have to have about a 1% chance or lower in order to make it worth not doing the LP because you do more good than harm by not doing the LP. In other words, you have to have an over 1% chance of having the subarachnoid that's aneurysmal in order to make it worth doing an LP, more good than harm. Okay, so that leads to the question, where did we start? If we want to get to 1%, where are we starting? Well, if we're starting with the patient in front of us and it's a subarachnoid hemorrhage we're worried about in a worst headache of life, thunderclap patient like my 62-year-old, then this is one of the older studies that talks about thunderclap headaches. And this is an older study too, and this is another one, and all three of them suck. So forget them. I'm sorry I showed them to you. Look at this one instead. Why do the other ones suck? Because they're thunderclap headaches and they include things like the patient comes in obtunded. You're not wondering whether to go down the road of intracranial pathology. Right? You figured that one out. So what we're worried about is you're neurologically totally intact, and that's this study. 100% totally intact, acute headache the way we just described it, and that's this study also by the same group. The first one's 600 patients, the next one's 3,000. A lot of patients in these studies. And these patients are all prospectively followed with great follow-up, and what you find is the actual rate of subarachnoid hemorrhage among this group, and man, 8 to 10%, that's a higher risk group than I am going down the road of subarachnoid hemorrhage on most of the time. It's not 1 out of 10 when I'm doing the LP that I find, a positive. So 1 out of 10 is what they're saying is a subarachnoid hemorrhage in this group of acute onset headache. You go in there, you go down your road of getting the CT, and some of them are positive, and then you get the LP, and some of them are positive. 8 to 10% are positive overall in that group of acute headaches. That's a very high-risk group, and that's why they got enrolled in those studies. Now, starting at 8 to 10%, we want to get down to 1% or lower. Can you do it clinically? Well, you don't actually work up every single headache as a potential subarachnoid hemorrhage. You don't do an LP on every headache where the CT was negative. So obviously you're clinically ruling it out a bunch of the time. You've decided this one's not a very good story, this one's got a history of migraines, whatever. So you've obviously gotten below 1% or below an even lower threshold, whatever your threshold was, a lot of the time. So that's a lot of the time you get there. You get there without doing anything other than using your mind, and you've been right most of the time. Maybe every now and then you're sending home that subarachnoid hemorrhage that you missed. Anybody know of a case that they missed and they came back as a ruptured? Yes, actually, good, 2 people. All right, that's good. That's almost as many people as have caught an aneurysmal subarachnoid hemorrhage. We have a good balance in the room here. It's perfect. I know your case. Man, bad case. I mean, ladies and gentlemen. Actually, this was like a migraine patient. This is a patient with migraines and had a very similar headache to her migraines. This is a patient, nobody should actually be tapping, even seriously considering tapping, particularly after we go through this. Anyway, so you don't work up every headache, and you shouldn't. So the clinical path can get you there. On the other hand, there are high-risk clinical characteristics that are worth knowing about. In some of this really good data, the high-risk clinical characteristic are things like, here's the actual data from the best study ever done on what's the high and the low-risk clinical characteristics. Well, it turns out onset during exertion is a high-risk characteristic. You knew that. What I like is that onset during sexual activity is not predictive, but exertion is. It's become a little too easy, folks. Loss of consciousness, bad. Bad. It's bad to lose consciousness. Shocker. If you have a thunderclap headache and you're unconscious, that's not good. So this doesn't shock anybody, but it turns out that really is a high-risk clinical characteristic. And then also vomiting and neck pain or neck stiffness. Coming by ambulance, probably 2. That one might be site-specific. But vomiting and, I don't mean anything, vomiting and neck stiffness or pain, those are things that are predictors of badness. So it turns out those really do elevate the stakes. That makes it more likely. So that's worth knowing. You should know that, because when we go through this, knowing the high-risk clinical characteristics, very, very useful. You'll see why in a sec. So now the question is, all right, so some clinical characteristics can make it more likely. Not that many make it much, much less likely, but there are some make it more likely. Clinically, we sometimes rule this out on our own. Now, can we get to less than 1% by doing a CAT scan? And that's the whole point here, right? If we can get to less than 1% doing a CAT scan, then we're done, right? Well, how often can we get there? That's the question, and this is the landmark study. You should know about this. You've probably seen it. You've hopefully read it. It is definitely a landmark study. There's a good chance you'll never see another study like this again in your lifetime. This is 3,000 patients, meticulously followed, 98% clinical follow-up, all enrolled. If they got a CT for a headache, they had to be an acute headache the way we described it. And the details are 11 emergency departments throughout Canada. They had the acute headache, but they were neurologically intact, just like my 62-year-old. 3,000 patients plus, 240 of them had subarachnoid hemorrhages. 240 subarachnoid hemorrhages. It's unbelievable. 7%. What did the CT head do? What was the sensitivity of the CT head for subarachnoid hemorrhage? Overall, 93%. Specificity, 97. Actually, they claimed 100. We moved that down. We don't believe them. So 93% and 97%. How about sensitivity? Less than 6 hours after the onset of the headache, sensitivity, they said 100%. I don't believe them. We said 99. So we're lowering all these variables to make it even more conservative. 97% specific again. And then after 6 hours, 86% sensitive, and the specificity 97. Now, likelihood ratios. There are your negative likelihood ratios. And that's the number we need to calculate the likelihood that they actually have an aneurysmal subarachnoid hemorrhage after a CT that's negative. So let's do a little bit of Fagan. Everybody loves the Fagan nomograms. Now, if you don't know Fagan nomograms, you're fired. Learn them. Get to know them. This is how they work, and this is where they're useful, is exactly scenarios like this. You start with 13%. Why did we start with 13%? I thought we said 7. Well, it's 13% in the patients who come in the first 6 hours of their headache. In that study, 13% of them had an aneurysmal subarachnoid hemorrhage. That's a huge rate. Actually, just subarachnoid hemorrhage, not aneurysmal. But if we just play subarachnoid as the aneurysmal in this case, 13%. And you can see what happens right there. After a negative CT, you are down to 0.5%. You're well under 1%. So, under 6 hours, you're under the test threshold with a negative CT. You're there. Now, the big question, what about if it's after 6 hours and the CT is negative? Here's what happens. You're still under 1%. You're still under 1%. Now, obviously, there's some judgment here. If you're on hour number 7, you're in a good place. If you're on day 3, it's different. And you're going to have to apply some judgment there because there's a sliding scale, and this averages all those people together. So you're probably over 1% when you're on day 3, right? Or day 2. But when you're at 8 to 12 hours, you're under 1% unequivocally. Now, let's imagine you're over 6 hours and you also have a stiff neck. Your pretest probability isn't 5% or 7% or 13%. When you have an acute headache, and remember, acute headache starts at 7%, right? That was the whole cohort. Now add on a high-risk feature like they've got a stiff neck. Now the chance they have a subarachnoid, 26%. Now you're much higher. At 26%, when you start there, the CT that's negative gets you to 5%. You're well above the test threshold. You should be doing the test. There's more good than harm that comes of the test at 5%, substantially more. So 5%, well above the test threshold. That's a big deal. You need to know that number and remember it. 1% and over is the test threshold, 1% and under. And you may have to do a little calculation with a Fagan nomogram every now and then when you see these patients to figure out where you're at. Now, what are other people saying? Am I crazy? Are we crazy? This is an editorial written in the journal Stroke this year by John Edlow, one of the world's experts on subarachnoid. We believe practice should change. Neurointact persons, CT less than 6 hours, no longer need an LP. Okay? Under 6 hours, the dishes are done. You don't need an LP anymore. This is acknowledged in editorials by the top journals in the world. Other people are saying it. You're safe on this one if you want to go this route. Now, your attendings may not be so into it. Keep that in mind. I want to be their friend. I like them. Don't get me in trouble. Talk to them before you make this decision on your own. Okay? But this is what you need to know about the literature and where it's going and what the future looks like. So here's the potentially new model. A CT that's negative after an acute headache, less than 6 hours, you can stop. You're done. Over 6 hours, I think the harms are greater than the benefits, and you can probably stop, but you have to apply some judgment there because if you're on day 3, you might be over the test threshold. There's a sliding scale of sensitivity that goes from about 100% at 6 hours down to about as low as probably in the range of 60% when you're at 3 to 4 days. Keep that in mind. Other high-risk features, and you're over 6 hours, you got to be doing the LP in that scenario. By the way, high-risk features and you're under 6 hours, you need at least 2 of them to even approach 1%. So if you're under 6 hours, you can have a stiff neck, and it can be onset during exertion, and even in that scenario, you're basically under 1% or pretty close. So you might do the LP when they've got 2, but 1 you don't need to. So LP benefits greater than harms when you've got greater than 6 hours and at least 1 high-risk feature. So we would suggest for number 2 and number 3, this is a time when you can talk to your patients about all those bad things and good things that can come out of this. And this can be a shared decision-making model. So what happened to my 62-year-old? She was the mother, you'll recall, of the cardiology fellow in the institution. So she and I talked about whether or not to do the LP. She said, I don't really want it. And I said, okay, we won't do it. She called her son. Her son said, no, you got to do it. So we did it. It was negative. The CT head was negative, and the LP was negative. So after the LP was negative, then what happened, do you think? She got admitted. She got a CT angio. CT angio was negative. Thank God. Oh, but wait. Then she got an MRI, MRA, because they were like, it was a good story. CT angio, by the way, is more sensitive than MRI, MRA for aneurysms. More sensitive. This is known. But she got the MRI, MRA, and then she went home. Oh, wait, no. Then she got a cerebral angiography that does carry with it, that 1% stroke rate. She, frankly, ended up doing okay, but her final diagnosis was thunderclap headache. It just happens, man. Sometimes it happens. So take-home messages. Let evidence drive your practice when you can, and there was the evidence. Subarachnoid hemorrhages are potentially devastating. You should be looking for this diagnosis, but they are uncommon, and you need to keep that in mind as you're doing these calculations in your head. If you miss one, it doesn't necessarily equal sudden death. You should know that. There's a 10% difference in outcomes. It's not everybody dies. The test threshold is always got to be in your head whenever you're doing a test. LP when the benefits are greater than the harms, and really seriously consider shared decision making, because now you know the numbers, the 1% thresholds, and you can make some decisions when you have these numbers in your head. So thanks for your time. Appreciate it, and we're almost on time.